we don't have a name for this yet. I don't know what it will be called because we're doing this lecture series. So that's more for Jimmy. So everyone today. So if you don't know me, I'm Miguel Escalon. I'm the residency program director at Mount Sinai Hospital for Physical Medicine and Rehabilitation. We have a good friend with us here today, Alex Elegudin. And I've invited him on, whatever this is, to talk about a little bit about, what it's like living with a physical disability, and to tell us a little bit about himself and kind of just get into some topics that you might not get the chance to every day with people that you interact with as physiatrists, and unless you really ask or delve deep. So that's what we're going to try and do, and we'll see what we hit upon and where this goes. So I'll let Alex say a quick hello, maybe introduce himself a little bit, and then we'll just kind of get into the conversation.
Cool. Thanks, Miguel. It's great to be here with everyone. So my name is Alex Elegudin. The next part of my intro is not usually what I say when introducing myself, but I'm a C5, C6 quadriplegic. I sustained my injury, give or take, about 20 years ago in a deer-related automobile accident while I was in college. But we'll talk about some of the journey today, and it has been a long journey. In terms of what I've chosen to do with my life since then, I've spent a good amount of my time in government advocating for change, both on physical accessibility in our society, as well as how agencies and kind of organizations serve people with disabilities in our community. I was the accessibility chief at New York City Transit, overseeing how accessibility works on buses, subways, and paratransit. I was the accessibility manager at the New York City Taxi Limousine Commission, helping the agency regulate taxis and make both taxis, Ubers, local car services more accessible to those with disabilities. And one of the things that I've really take some pride in is I did start a nonprofit organization called Wheeling Forward in 2012 to help deal with some of the barriers that people with disabilities face. And disability is a little bit of a broad word, but when I say that kind of today, I'm talking about physical disability, and not exclusively those who have paralysis or are wheelchair users, but a lot of our work and a lot of what we've tried to do is in that direction. And I like to think of our work as targeting the 5 main areas of things that kind of people need to be successful in life, or people that need to be active in life, which is transportation, healthcare, housing, employment, and generally healthcare and education. Sorry, I need to do that again. The 5 things that individuals generally need in life to be kind of successful and have a meaningful, active life: healthcare, employment, housing, transportation, education. Am I getting those right?
I think it sounds good.
I think I'm forgetting one.
Well, there are 5. You're definitely saying 5.
Yeah, I just don't usually say education. Housing, healthcare. Sorry, I just wrote this out. Sorry that this is bothering me.
It's all right.
Nope, that's them. All right, one more time. So generally try to help individuals across the 5 major areas, that kind of have to do with living successfully or engaging in the community, which are healthcare, education, housing, transportation, and employment. So across those areas, anything we can do to kind of nudge both our society and individuals personally forward is what we try to achieve.
Nice. So I want to touch on, I'm glad you said all that, because I think we can touch a little bit on all of those things. Most of what we're doing was targeted at people in training. rehab residents or fellows. So I'm just curious, because you did your rehab at Mount Sinai, right?
That's correct.
So
Back in the days when you had a nice long rehab stay.
yeah, back in the day when you had to go uphill both directions. Mount Sinai always feels that way though. There's always uphill whether you're coming or going. So one question I have though is like, I'm putting words in residents' mouths, but you may not always feel as a resident or fellow, at least when I was in those positions, that the buck stops with you. There's an attending there and therapists that are more senior. What do you think that the residents or fellows could have a big impact on people's lives after rehab by doing certain things during the rehab stay, acute rehab stay?
Absolutely. I will say that in my personal kind of experience, in my personal view, rehab is a little bit of it's really a rebirth. You know what I mean? At least for me. I went from being an active member. I was at Carnegie Mellon University at the time. I was actually playing football at Carnegie Mellon. Say what you will about playing football Division III, but I was active in college and doing all these things, and then it all shuts down. When you have your accident, it's like they took a little needle and popped your muscle was a balloon, and they popped every one of them. It's relearning how to brush your teeth, relearning how to eat, all these things. And I say that to say, during your process of birth and rebirth and growing, everyone who touches you can have an impact. And to be candid with you, I really believe that my therapists, specifically my PTs and my OT, who we're still friends with to this day, had probably one of the biggest impacts on me. And I say that because they took time. We went out to things like the park, and they took me out to the movies, basic things. Some of the strongest impact they had on me was outside of the actual therapy sessions that we had. And I think a similar impact can be had by anyone. If somebody gives you the time, and I understand that, all residents and attendings don't always have the time to take you out to strolls in the park, but, understanding each person is an individual. Everybody has different curiosities about, hey, what's going to be next in my rehab? What's next in my life? Some people care about, how are my relations with my wife going to be? How am I going to go back to work? Am I ever going to be able to drive? Everybody's a little different. And what I found very comforting or helpful was those questions that I raised. Maybe somebody didn't know at that moment, but they took some time to go and try to figure it out, even if it wasn't directly in the lane of a physiological problem that has to do with my bowel or bladder. Maybe it was something else. So I think understanding each person's plight, understanding where they're trying to go, and kind of advising them a little bit, whether it's by giving good information or giving them a good resource to follow up to, can have incredible impact.
What could they mess up? Like, what could a resident mess up by trying to do something like that, or by saying a certain thing? Is there anything that we shouldn't be doing?
I'd like to say generally residents can't mess up, but that's not a wholeheartedly true statement. I think some of the some of the mess ups that I've seen, and I've been doing this for a long time, in terms of mentoring people, helping them to transition and hearing what they have to say, are jokes that are distasteful. If we talk about general bedside manner, things like, well, you're going to be okay, but you're probably never running a marathon again. On one hand, not exactly bad, but at the same time, something that can be pretty jarring.
Right.
I share that story. I'll give a little tangent because my good friend Yannick, who's also my co-founder at the organization Willing Forward, and you'll probably hear from him at some point. He actually remembers that that was one of the first things that was said to him. And it was so jarring and so kind of, painful for his parents who were next to him when whoever this doctor was said, hey, you're not going to be running any more marathons. Um, Although the story has a good ending because Yannick has done well over 10 marathons in a wheelchair, and
Hmm.
he found a way past it. And I say that as a little bit of like a perseverance story, but ultimately jokes of that nature are a little bit, distasteful, and sometimes people aren't ready for that. I'll say the second category of things that can kind of be a little bit off, in my opinion, and this is a very difficult category, is expectations. It's a very difficult thing as a rehab doctor, as a resident, as a therapist, as anyone. Sorry, you're catching all those
It's all
beeps.
right.
Okay, I can go back a little. I'll say it's a very difficult thing. It's a very difficult thing as a resident, a rehab doctor, therapist, or anyone to, find that balance on the topic of expectations. How do you guide someone and push them and promote them and encourage them to be all that they can be, and really beat this, spinal cord injury, and beat whatever it is they're going through, but at the same time don't set unreasonable expectations where, they might not be able to meet them, and then at that moment, if that ever happens, they're incredibly depressed or think that they
And
failed, or whatever it is.
yeah, I
So
mean,
mhm.
it sounds like, I mean, it's complicated, so I don't want it to sound simple, but it sounds like listening is very important, like taking the time to listen and then not taking hope away, but not giving false hope.
Absolutely. And that is really a craft. I think that residents and rehab doctors in general are in unique situations to be able to give that kind of advice for kind of two reasons. One, they understand the, kind of like medical situation really well. And based on their experience, they have a sense of where you're probably going to end up medically. I mean, not perfect, but they can understand that. And two, they have experience. They've seen how others have done in the past, and that kind of gives you some insight into probably where you can go. And if I was a resident or rehab doctor, I would take, and this is, I say this with a little bit of a grain of salt, take the example of somebody who's done really well. You've got the gamut of hundreds of patients that have come through the rehab floor with various injuries. Take the take the top 5 or 10% and use those as examples where to hold others to. And I don't mean literally say,
Mhm.
this is John and this is how he did, but the things that they were able to achieve at their level of injury. You know, even for myself as like an advocate or a mentor who's, a little bit, um, who's been around, I think about, oh, I know folks at, C7 level, they're manual chair users, they're pushing through the streets.
Mhm.
I mean, that's top 5% kind of stuff at C7 to be, transferring independently, be almost fully independent. And that's my standard for folks who I meet who are at those C7 levels. Then I think about C5, C6, and you think about, okay, who's doing well at that? You can drive at that level, you can do this at that level. So use kind of some of that learned experience to promote others in realistic ways.
Yeah, and those are really key points. And I know I didn't get that maybe until I came to Mount Sinai for my fellowship in terms of, I mean, I kind of understood, but I didn't take it, I didn't feel like it was always my responsibility because there were other people there. But what I'm hearing you say is it's everyone, like from the nursing aide to the attending to everyone in between. It's like a team effort, and anything anybody says could positively or negatively affect.
Absolutely. And I mean, I'll even take it one step further. I think I've had residents and medical doctors, and throughout kind of my journey, sometimes all it takes is a call, right? A lot of those kind of post rehab things that you're dealing with as a patient, have to do with social work or certain, kind of other areas, and they can be overwhelmed, and I totally get that. But if you as a resident understand that there's something waiting either in social work or some other discipline, and you put in an email or you put in a call, it goes incredibly far. One, in terms of what you're doing for the patient, and just doing all you can do. And two, when the person feels it on the other side, hey, there's a resident who's interested in, hey, there's somebody who's pushing for this, it absolutely makes a difference. We're all human, and everyone's got large caseloads. And if that's what you can do to help push a process along, or get somebody home a day faster, or make their transition home that much smoother, then you've done one more thing that you can do to make it better for someone else.
Yeah, it's complicated and simple. So, here's what I would say, just in kind of to jump forward a little bit, is, to someone that might look at you and say, okay, Alex, I understand his level of injury because I'm a rehab resident or a doctor. He seems to have got it, he's got it put together, look at him, look, he's dressed nice beard, multiple jobs, multiple degrees, you're married, and it seems like, to perhaps a semi-trained eye or untrained eye, that you got no more problems, everything's gravy. What should residents know about, life after inpatient rehab and the kinds of things you might deal with?
Yeah, I'll say this, Miguel. I mean, my wife might disagree about the beard part, but otherwise, maybe you're right. But look, I will say that this journey is really difficult, right? I think it goes in stages. It's funny. I used to get very upset when I was early on in rehab, or kind of my first few years of dealing with this injury. People would say, "Oh, you're like in the first 1 to 3 years," and I was always like, "No, why are people bucketing me? Why am I getting kind of stereotyped?" Then people were like, "Well, it really takes 5 years." And then I hate to say it, but the longer that I have lived with this, it's really true. Because living with this disability is a lot about setting up a system. It's a lot about learning and nuance. And what I mean about setting up a system, right? Especially, I'll use my own case, C5, C6 quadriplegic, right? I need help with getting up, cathing, bowel, getting dressed, all those kinds of things. And, at the time, my goal was to go back to school. I was 19 when I got hurt. So I wanted to go to college. I ended up going to law school. That's one level of getting your system kind of together, because when you're going to college, okay, you got to get ready, you got to do your work. All right, you show up 15 minutes late to class. Okay, you missed class one day because your aide didn't show up or was late, or you were on your way to class and you had an accident and you had to turn back. And in college, there's a little bit more flexibility, but still difficult because you have to submit assignments on time and you can get accommodations. But I say this to say that's one level of kind of getting your life together. And I often say that what I learned in college was more about living with my disability than it was about whatever my degree specialty was in. And I know that sounds kind of funny, but to me, it really was true. Like figuring out how to show up every day, figuring out how to participate in class, and just deal with students, right? There was a lot of students, a lot of times that might look at me like, who's this guy in a big power chair in class? And until you speak, they don't realize that you still have a head on your shoulders, and that you might be, you might actually be somebody who has something intelligent to say. My favorite was always, usually after the first time I spoke in class in college, at least one or two people would come up to me and say, "Wow, you're like really smart. That was really great, your response." I always find that interesting, because on one hand they mean so well, but on the other hand they couldn't be more offensive.
Right.
And I never took it offensively. I always tried to take it in the good way and educate them. But it goes to show you kind of the things those things can be jarring at first. So that was kind of like one level. Then after college, you end up trying to find a job, and that's a whole nother level of having your system together. Like, you can't be taking days off all the time. 2 hours late isn't something that your boss understands, because like, as you were transferring, your catheter came off and you got urine all over the place. You know what I mean? So it's it's how do you build this up to really have an understanding of how does a home care work? How does your body work? How do you predict your, urine and bowel situation? How do you take care of your skin? What do you do about UTIs? And I say that to say it's a lot of work. It's really challenging. And that's just the things that are within your control. And then there's the world of things that aren't within your control. When you're traveling and taking a bus and, the bus lift doesn't work, or you're on the subway and the elevator doesn't work, who do you complain about all these things? And on one hand, each one of those things are manageable when you become savvy enough, which is unfortunate that you do, but they're all 2-3 hours of your life, getting around them, fixing them. And on any given day, the frustrations can really boil up. It's like, it's one thing to have to try to, deal with all this, and then it's just setback after setback. And unfortunately, the way I deal with it with myself is I've tried to train myself and prepare myself for those kind of things, and have a like kind of don't say no attitude, and just push through it. But it's not easy. The frustration builds up, the challenges build up, and there are daily setbacks, and then there are like massive setbacks, right? I was back to work at some point, and I developed a wound a couple of years after my injury for a very weird situation. Bought a new pair of pants, and there was like a piece of metal in them, and it got under my skin, and I didn't catch it for like a day or two, and ended up fighting that wound for 2 years. Ended up getting flap surgery in the end. I wasn't out of life for 2 years, but I was incredibly limited and had to stay out of my chair at times. And it's very difficult. One of the biggest challenges that I've seen with folks, specifically with various forms of paralysis, is they'll get back to it, and they figure it out, and they get back very quickly, and then they have a setback from a secondary complication, and then that's it. And then sometimes they don't recover from that, because they're like, well, why am I trying to do this again? It's going to be some bad UTI. It's going to be something else that sets me back, and is the again, I'm back to square one. There's no point, because every time I climb up there to figure this out, it sets me back. So I always try, as an advocate, as a mentor, to try to prepare people for that, just to be like, hey, you're doing great. Keep it together. Look, this thing, whether you're 5 years, 10 years, 15 years, unfortunately with SCI, there's always something. You look at folks like Christopher Reeve, who died from a secondary complication. You look at others. You could be as good at managing this as you can be, and that's no easy task, and still something can sneak up on you. But I think the best way to deal with it is to have an understanding of how difficult it really is, to both take pride and push yourself to achieve whatever your goals are, back to school, back to work, being a great family man, being a stay-at-home mom, whatever that goal is, like, get there and achieve it. But understand, what you're dealing with, and kind of be balanced about the expectations of your approach.
Yeah, there's a lot there. Certainly there's a lot of medical things, there's maybe some opportunities for better follow-up and education long-term. And then folks like yourself, or organizations like Moving Forward, mentoring and advising people in a situation that you could understand, or try to understand at least, how it could seem like hopeless at times if you keep just getting swatted down. What about, though, I think one thing that I kind of started thinking as you were speaking, which is semi off topic, was, you've had a lot of jobs, positions within the city. And just as you're speaking, you mentioned like elevator out or whatever. It strikes me that, the city and the world we live in is not made for people with disabilities. Basically what happens is it's made for people without physical disabilities. And then we try to like jerry rig stuff for people. Is like, okay, I don't mean to be mean or anything, but it's kind of like, okay, have this and shut up about it. Like, this should be good enough for you. Some people use the word ableism and different things like that. I'm just curious if what your experience is or thoughts are there, given you kind of have been on both sides of it. You've been on the governmental side trying to help and fix, and you certainly have been on the other end.
Yeah, absolutely. It's a really great question because I think it goes across a couple different topics. It goes across like mannerisms that people have. It goes across like the physical environment of your workplace. It goes across the relationship you may have at your workplace, right? And I'll touch on a couple of those. I'll start with the workplace first, and then talk about kind of like the way people have etiquette towards people with disabilities. But when I first was in law school and I got an internship at a courthouse with a judge, I came into the office day one, and they put me at a desk. It's kind of like a table, and it's very low, right? I sit in a power chair, so it's clearly not accessible. And what do? I try to be like a good, I don't want to cause a uproar on my first day. I sit sideways. So, I turn my chair sideways and, kind of adapt myself to it. And I do my work, and I sit like that for about a week until somebody in the office realizes, hey, that doesn't look very comfortable. You're like sitting and typing sideways. And, I go, yeah, but it's okay. I can figure it out. I'm fine. And I was still kind of young in this journey, and I kind of let that be the case. And I did my whole internship kind of sitting sideways, typing sideways in my chair. And I say that to say, I look at that situation now, many years later, and I think it was both a success and a failure. In terms of, I probably failed in advocating for myself. It's a courthouse, it's the government, there are laws. I could have easily asked for a wheelchair accessible desk. They probably could have accommodated it, and they could have learned from it, and I could have been in a better situation from it. And I didn't really understand my voice then, that, it's worth speaking up for such a simple thing. It's good for everyone involved. I say it's kind of a success, like, oh, I dealt with a problem, I didn't cause a scene, I didn't make anyone else uncomfortable. And, I kind of have difficulty saying that that was a success, because in our world of like advocacy and empowerment, you're not supposed to do those things. But I still believe there is this balance, right? When you're in the workplace or you're anywhere, there you have to look at it a little bit objectively, and it's very difficult to say that, because I'm a person that might go up to some very old, landmark building that was never meant to be accessible. It's got all this historical value, and the government says, no, that's a landmark, we can't make that accessible. And I'm like, well, I kind of get that, but that also means I can't participate in it. And it's kind of like a bummer. And then the other hand, you try to stand and be like, well, I kind of get it. And by the way, my job today is I work at Columbia University, and I oversee campus accessibility for Columbia. And I face this problem a lot. Columbia has some very beautiful and old kind of legacy buildings, and we're always trying to how to make them accessible for students. And there's always this question. But going back to the topic a little bit, I think that's something that is worthwhile for everyone to understand. I would always push folks in this condition to, advocate and empower first. Let somebody tell you no. Let somebody explain to you why something can't be done. Because I think often than not, the easier way for whether it's a government or an employer or an agency is to say, well, it's kind of difficult. We're grandfathered in, it's always been like that. I think the better thing to do is, no, I really want to make this accessible. We're going to find a way to make this accessible. And you try really hard, and then you happen to fail at the end. That's a much better course to take. Give it a try, look into it, because a lot of times you'll discover, and what I've learned for many years in working in kind of barrier removal and physical access and ADA compliances, there's a way. People have figured out a lot of stuff. The bigger problem is folks not trying. Mm-hmm. So I kind of say that from a environment place to share as an example of encourage folks to promote their environments to be better, but also have an understanding with what they're dealing with. I mean, there was a time where I went for an interview at a law firm, very small, incredibly small office. I mean, this was more than a decade, more than maybe ago. And they were very interested, and they we want to figure this out and make it work for you. And I actually said, I don't think this is going to work. I can't even turn in here. It's not really designed. I didn't see a way where you could change the nature of the office unless you're going to get a new office. And asking my future employer, to get a new office just to hire me is certainly something that's possible, but not something that, I would think of going that far.
Mhm.
And I'll just say two other things. I mean, then there's the relationship, right? Getting out of the physical access of kind of how you deal with that, and have the world adapt. Look, in terms of physical access, the world kind of has to adapt to you. Unfortunately, a lot of things that were built before need to be adapted, whether it's, blowing up a bathroom, making it accessible, which might sound like a big thing, but it's a win for everybody. It's something that I always push for when I work somewhere. Hey, this bathroom's not accessible. I know it's potentially a big job, but you can do it. When you're dealing with your bosses in terms of, employers or whoever in the relationship, that's a different thing, right? If especially in today's world, if I ask my employer, hey, I'm having like a bad disability day, try not to elaborate on, and that means like my bladder's off the chains and, something's going bad. I don't exactly say what it is, or hey, I had like a bowel situation and, it's not a thing where I can run to the bathroom 5 times during the day. You don't actually say that. But when I say I'm having like a bad disability day, I'd like to work remote today, or, I want to take a half a day. It's just, it does. Some bosses I've had have no clue what that means. And they're like, oh, they're probably thinking, oh, is he milking his disability? He's playing the disability card. And then I've had other bosses who understand it incredibly. They know to the T exactly kind of what it is. And they go, of course, we'll work with you. And that doesn't, people need to understand that doesn't take away from their job or their ability to perform their job. If they need an accommodation for a day or half a day, or they have to address their needs. And sometimes you have to have your own voice. And that doesn't mean filing complaints with HR. It means educating. It means kind of finding a way to get that message and that knowledge across to someone else. And I say you as residents, I mean, how do you deal with these big topics in a short kind of stay? You don't necessarily. If somebody brings it up, you find a way to talk to them. I know like some of the series that Mount Sinai has, for example, on employment, they may be long, and you may be busy doing other things, but it can give you some of the knowledge, the right phrasing to explain to someone, hey, if you go to work, you can absolutely have an accommodation to deal with your kind of needs, or you learn other tidbits of information that you can share with patients and push them in the right direction. So I say some of that, and then there's the etiquette that you carry yourself. Some of the best, whether it's therapists or doctors, I always find it interesting, and everybody has their own approach. I had a rehab doctor, or actually I think she was a PT who, anytime she'd speak to me, she would get on a knee to be eye level. And I use that as an example of something that like it comes across so powerful in a good way, that somebody's willing to do that. Somebody has that level of understanding. And I'm not encouraging all of you to do that. That is not a requirement. If you take a disability etiquette course, people will kind of say that. Some people don't get on a knee, they'll just pull up a chair. There are different ways to do it. But I think some of those things from an etiquette perspective, when people have that level of understanding to, to kind of, I struggle with this because the word is like disability sensitivity or disability etiquette. And I don't want anybody to be particularly sensitive towards me, but an understanding of how to have that proper etiquette based on what a person's condition is incredibly important, and helps to bridge the gap between the difference of you being some resident that is just like calling out my vitals and making sure my bowels go every day, to me being a human being that has a life. And how do we connect on that level? Because that's ultimately what rehab is about, right? Getting back someone to living their life and as close to what it was, or as close to what they want it to be.
Yeah, I think those are good points. And I think of like little examples of stories you hear when you take these kinds of courses, like, if you see somebody's like going to cross the street and they're in a wheelchair, don't just automatically go up and like push them across the street. You think you're being helpful, but if you think somebody needs the help, you can ask. But so there's, it's hard to put yourself in somebody else's shoes especially when it's something like if you don't have that experience. So the courses can be helpful, or even just talking to patients that have come through, or the therapist and stuff like that. As you're mentioning some of the things you were talking about, I started thinking about a few of the patients I have that might live in like Queens or Brooklyn that have paraplegia or even tetraplegia, and they live in walk-ups. I think, well, first of all, that's horrendous. Like I've heard stories, people like have to like throw their wheelchair down the stairs and they like bump down the stairs, and then on the way up, they're strapped in and they're pulling themselves up on the banister. Just insane stories. And then I think, well, what can I do? Right. And I don't know how much there is that I can do for that person in that moment. If they're in public housing or something, they're on some kind of list where they're, no offense to people with like knee arthritis, but their disability is viewed the same as some, they don't necessarily get priority. So this is just one example. I mean, there's a whole host of things we could talk about, but how could a physician or resident, somebody, get involved to help make change on a level that's greater than individual?
Yeah, this is a great question, and I'm actually going to take it back a little bit.
Okay.
When I look at physicians or residents and kind of their role when it comes to outside the medical component of giving the care that a patient needs, I think there's what can you do when the person is in kind of your care, inpatient, or in the rehab unit, or wherever it is, the person's in the hospital. And then there's what can you do afterwards, right? When they go home. And I will say that Miguel is one of the best, if not the best, that truly understands and puts in the effort to help patients in the latter. When people go home, it's very easy to think, hey, they went home, they're going to figure it out, or even worse, to be honest, they went home, they got all kinds of support there. No, that is just not true. People do not go home and they don't have more support there. There's not 10 social workers and 10 other agencies. There's still major gaps in the system. And that's kind of why organizations like Willing Forward exist, and why I've worked so hard in government to try to create those additional layers of support. But I say this to say, you can have a difference, whether it's making a call and a referral to an agency, and you may not know what that agency is now, but you may have somebody, hey, they've got a home construction issue and there are resources available. You put in a call or you send an email there. And Miguel does this all the time. And it actually, look, I'm not going to say it actually works. Is it 100%? Are we able to, one, myself as a community kind of advocate and organizer, are we able to solve every problem? No. Does every referral that Miguel makes, does it work out every time? No. But do some of them? Absolutely. We can only create a system if we care and we understand, what we're doing and where we're referring to, that starts that trajectory. You know what I mean? When I was in this rehab, 15 plus years ago, folks that were put into nursing homes, whether they have paraplegia or quadriplegia, it was honestly a lot of times a life sentence. There wasn't enough support in this form of government vouchers, accessible housing, different preferences. In today's world, it doesn't have to be so. In today's world, I believe that if you really want to get out of a nursing home, you can. I say that to say there are some folks that go in there and have some, psychological and mental challenges where they get stuck in that nursing home, but let's say you're an individual that really wants to. I believe there's enough support today to be able to achieve that. It's not a short process. It's not an easy one, but it's possible. But I think it behooves you as a resident or a physician to understand the top 10 issues. Miguel mentioned one, inaccessible homes and stairs. I'll mention, nursing homes. There's others, folks that don't get their wheelchairs and don't have mobility. There might be, home care issues. There might be a plethora. Pick the 10. Become educated on those 10. Find a potential resource, something where someone can go. Maybe something that you can do directly, but obviously you have your jobs every day. But become educated on those top 10 things, and find a way to tell someone, hey, you can do this. Hey, you can do that. Hey, you're having government benefit issues. Maybe you find a good agency or somewhere to refer to. And that's the best that you can do. But the worst thing you can do is, one, not even think about following up or understanding, and that obviously depends as a person. Do you see the person as an outpatient? Do you see the person as a physician? But sometimes I've had therapists and some physicians who just check on you, every 6 months. And that depends, that's not for every situation. I was hurt in college. I was very active. So I was a kind of unique patient, had a unique dynamic in rehab. But that's to say, there's a way you can follow up, see how the person's doing. I think one of the worst and scariest things that happens is someone goes home and you don't hear from them from a year. You ask yourself, what does that mean? You haven't heard from somebody from a year. You might be like, oh, they're probably doing great. They're so on with their life that they're just too busy for me and too busy for everyone else. Unfortunately, with this condition, that's often not the case. Sometimes, more often than not, and I hate to say this, that person is home. They might be isolated. They might be depressed. They might be having some serious barrier issues that maybe are medical or non-medical, and they're not in a good place. And that year, that kind of passed by where you didn't check in on them, is a year where they have really struggled. And it's a year where they went backwards and not forwards, and I'm not saying that, you have the power to solve that, but your call, you identifying the issue, you bringing that to a social worker, you bringing that to a psychologist, you bringing that to a community organization, a lot of times can be the difference between that person starting to move forward again.
Yeah, and you bring up some really good points. And I'm guilty of this. I think we all have been at Mount Sinai. We have the Wednesday clinic. People come with spinal cord injury, and we have, we're discharging people with spinal cord injury from the hospital all the time. They're supposed to follow up. They don't show up to that first appointment. And then maybe nobody calls them. And then who knows what happened to them? Did they ever get home from the subacute? Did they not come because they're still at the subacute? Did something else happen, like what you're saying? Or did their wheelchair break and it's going to take 6 months to fix it? And so they're stranded for 6 months. So it's complicated. But I'll tell you, sometimes, I get some emails from people who say, oh, thank you so much, or you're a good doctor. And I'll say, sometimes, most of the time when I get somebody tells me I've been a good doctor, it has nothing to do with like a medication I prescribed. It's like they email me a question and I answer it. Or they email me like, hey, I think I have a UTI. And I'm like, okay, I put in a urine test for you and I sent some antibiotics. Take the urine test before the antibiotics, but you can get started. And they're like, oh, thank you so much. I've been called like 7 people and nobody answered me. So what I'm saying this to say, like, you don't have to know everything, like Alex is saying, but if you try even a little bit, it takes me 30 seconds to answer the email. It goes a long way. Like, it's always surprising to me, the stories I hear from people, like how hard it is to contact, like with a disability or not, like how hard it is to get a hold of their doctor because they just need X, Y, or Z thing done. So, it's hard, I think, on our end, because every year the forms are like quadruple for anything we have to do. But it is important, I think, if you really talk to the patients that you're seeing, to understand how much they appreciate it. And if you don't talk to them, you'll never know. And what you don't want is to have like resentment grow that you're like doing all these things and it's just busy work, because it still has an impact.
Can I say something about that?
Sure.
One of the things I don't often, just because I've become kind of busy as a person, I don't always have the time to like go to schools and give a talk to classes, or maybe go to companies that want to have an empowerment talk for their employees. And I would like to do it because I think it's important, because you spread knowledge. But one of the things that I always try to find time for is to go to a PT, and particular OT, but particularly PT schools, to talk to young therapists that are coming up and convince them to do neuro. And the reason I do that is, a lot of therapists, they want to go into, ortho or more geriatric type things, the more kind of broader fields, and at least stereotypically seem to have more opportunities. But I always, kind of pitch therapists, and I'm going to pitch residents in the same way as like, if you really want to have an impact on someone's life and on patients' lives, the neuro field, especially a field like spinal cord injury, is incredibly rewarding. I mean, the little things that you do make such impacts on people's lives to break down these little barriers, to break down these medical barriers, to help folks figure it out from a day-to-day basis. I mean, it's a relationship that goes, beyond like, I mean, I don't mean to say anything bad about primary care and kind of like, people are just checking in, or kind of in the ortho field when you're doing like knee and hip replacements, nothing offensive, or arthritis, nothing offensive about all that. And people need that help and support. But when you're dealing with this population, the challenges candidly are just that much greater. And anything you can do, and you're part of that system that I talk about, right? You're part of the healthcare system that somebody like myself needs to have in place, a doctor I can call, quickly deal with the UTI, a supply issue. You know what I mean? If I run out of catheters because I'm busy working and I didn't catch that I ran out of catheters and I need a new script, that's an incredibly important call, and how quickly can you get a doctor to fill that catheter script? Because if I don't have catheters for 2 days, or I dare think about reusing a catheter, I'm putting myself in incredible harm's way,
Yeah.
and the impact that you can have and the relationship you can have, it kind of transverses. I mean, to me, uh, even the standard, doctor-patient relationship, and it becomes, I mean, I hate to say it, more friendly, more like the second support system, second family that in some ways you can a little bit be a part of, because it takes a village, honestly. And hey, it kind of sounds like a lot and it's a burden, but it can work, you know what I mean? And then look, to me, I'm 20 years almost post. I'm not going to say it's perfect. I still have days where I spend the whole day in bed because my system fell apart, whether it's a home care issue or some other kind of issue. But most of the time it works, and most of the time I'm able to be out there, being a good husband, being a good friend, being a good son, being a good, employee, being a good advocate, being whatever it is that I want to and try to be. So I encourage you all to go down that path and find a way to make that impact, because it can be really, really rewarding and really give you a career you can enjoy.
Nice. It's hard, it's hard for me to keep talking. I feel like that is a nice closing soundbite. I will say, in case Jimmy wants to splice this in, just because you do a spinal cord injury fellowship as a resident doesn't mean you can't see other kinds of patients. So if you're interested, but you're worried like, oh, I can't only see one kind of patient, don't feel boxed in. And
Yeah,
also you
sorry,
could,
I
yeah,
was talking, I guess I was
yeah.
talking. So if they're assigned a spinal cord resident, that's like what they're doing, right?
When they're on a rotation, but then when you do a fellowship,
Okay.
you take the year, that's all you do. And then people
Mhm.
often feel after that when they finish the fellowship, they've signed some kind of contract that means like I can never see any other kind of patient again, which
Okay.
is totally false. I see patients with MS and
Yeah.
strokes and brain injuries, but I still have patients with spinal cord injury. So I just throwing that little plug out for them, to not discount the fellowship just because they might feel pigeonholed by it. So I think this went really well, Alex. It was
Cool.
nice.
Well,
Uh,
yeah, I mean, I think we covered a good amount. It's impossible to cover everything in an hour, but I hope we were, I hope we both show the challenges, show that you can overcome them, and most importantly, show that residents can play a role.
yeah, I think so. Well, I'll send this to, I'll end the recording actually
Mhm.
now and then stop recording.